All right, everyone see that? Okay. So looking at etiology and incidence and all of that, forming epidemiology, we know that it's found in type 1, and that's the primary population that we see DKA in, but I know I've taken care of some folks that have DKA that have type 2 diabetes with some of you, and that is usually found in this instance when, you know, their pancreas is pretty much toast and burned out. And so they are more insulin dependent as opposed to insulin requiring. And so we will sometimes see DKA in those type 2 diabetic patients. Or if they're super sick, sometimes you'll see DKA in type 2, but mostly when they have pancreas failure is when you'll see it in your type 2 patients. The hospitalization rate, I just thought this was a little bit of an interesting graph, kind of downtrended and then uptrended a few years ago. So as you know, we see plenty of it primarily in our non-compliant patient population, but you'll see it in other patients too that develop illness. So about 6 to 7% annually is our hospitalization rate. I just wanted to go over the physiology a little bit, sparing you the Krebs cycle and some of the minutia, but I think it's important to understand sort of physiologically why DKA takes place in the first place. It's one of my favorite things to treat because it's like you're watching physiology in action, you know, and things can improve so quickly and dramatically for people, and they feel so much better. So it can be quite satisfying as a physician to treat it. So the primary thing is insulin deficiency. So remember that we have to give insulin to correct these abnormalities. Sometimes you will get arguments from nurses or from other people that are involved in care. Why are you still giving insulin if the sugar is 100 and things like that? And we'll go over that a little bit more here in the next few minutes. But remember, the main issue that's going on here is insulin deficiency as well as the dehydration component. So because of the insulin deficiency, there's elevated counter-regulatory hormones. You have all those catecholamines and stress hormones. You have the cortisol, growth hormone. You also have increased inflammatory markers being released, as well as glucagon. And all of that leads to the increased hepatic and renal glucose production. So instead of insulin taking care of bringing that sugar down, we have no insulin, and so there's increased glucose production as well as impaired glucose utilization. So the tissues have plenty of glucose to use them for their needs, but they can't use it because there's no insulin. So that leads to this perpetual hyperglycemia that can't be resolved without your intervention. And so additionally, there's a release of free fatty acids from the adipose tissue. And then you have this fatty acid oxidation to ketone bodies. Beta hydroxybutyrate is just one of those. There are multiple fatty acids, free fatty acids that are released, but that's why you get your positive urine dip for ketonemia, and also why you get a metabolic acidosis. And so then because your glucose is so stinking high, it spills into the urine, right? So you develop glucosuria, and that leads to an osmotic diuresis, loss of electrolytes, particularly sodium and potassium, potassium in particular, and then you get the dehydration. So you kind of see the cascade that's happening here. It's hyperglycemia, insulin deficiency, acidosis, and dehydration, along with electrolyte disturbance. So what are the precipitating factors? This is where your participation is requested.
Infection.
Infection. Yes.
Hey, Dr. Bunch, you are allowing them to cheat because we're seeing the presenter view, so we can see the next slide.
What?
Oh, when you open PowerPoint, the presenter view is showing, when you screen shared, the presenter view is showing.
Oh, okay, well, so that little trick failed. I can't even back up. This isn't even fair, people. All right, so you know everything that I'm going to say. So, infection. We see this with minor infections. We can see it with sepsis. We see it with strokes. Sometimes people present with DKA who've had a stroke or any kind of neurological insult, honestly. Alcohol use, we have plenty of that in our area. So alcohol use can cause DKA. Interestingly, of the illicit substances that people can partake of, cocaine is a leader in causing DKA. Obviously, there can be many other things that can cause issues, but as far as DKA, cocaine tends to be higher than some of the other ones. Pancreatitis is a really common cause, and it's something for us to kind of keep an eye on, because you can have mild elevations of lipase with DKA just as it is. So pancreatitis may not be the precipitating factor. It may just be a concomitant elevation of lipase that is not necessarily related to a pancreatic issue. So just keep in mind that if the lipase is elevated, to be a little bit cautious as to whether or not you think that's truly the etiology. Heart attacks obviously can cause issues and precipitate DKA. Any kind of trauma, so your motor vehicle accidents, your falls, your hip fractures, things like that. New onset diabetes, this is a common way that we see it, of course, and some medications. I was going to ask you what those were, but you can see them. I think sometimes people, steroids is the classic answer, of course, but sometimes people aren't aware of the fact that higher dose thiazide diuretics can cause hyperglycemia, as well as things like beta agonists, a lot of albuterol, or back in the day we used to use terbutaline a lot in obstetrics. And so those types of beta agonists can cause elevated glucoses. Interestingly, SGLT2 inhibitors can sometimes paradoxically cause elevated glucose. Medication noncompliance is the primary reason that we see people come in with DKA. They forgot to take their insulin. They chose not to take their insulin. They went on a bender. So they have the alcohol use plus not taking their insulin, a variety of different things. Anyone have other things that have happened or other contributors? That you've seen for DKA? Nope, I covered absolutely everything. I'm so amazing. Okay. All right, so in the diagnosis, looking at our history, it's usually a short time frame as opposed to some of the other elevated glucose syndromes. And again, Dr. Shu is going to go into that a little bit more in depth when he talks to you. So it's usually a short time frame. Usually there's a precipitating factor. Sometimes patients aren't too forthcoming with the fact that they haven't been taking their insulin. So sometimes identifying the precipitating factor can be a little bit difficult. And sometimes it can be tough because we don't look for it. It's our job to look for it too. We may have that patient that comes in all the time with DKA because he or she doesn't take his or her insulin, but it's still our job to make sure they don't have pancreatitis, they don't have an MI, and things like that. They have the classic triad of polydipsia, polyuria, and polyphagia. Some people will have that. Some people will not complain of that. Some people will have weight loss. Others won't necessarily notice that. Those are probably more commonly seen in that like new onset type 1 diabetic. Vomiting and dehydration are fairly universal. Occasionally you won't see that, but just the whole mechanism of everything makes people feel nausea, and then a lot of them experience vomiting, which of course contributes to electrolyte disturbances. Many of them will have abdominal pain. That does not necessarily mean that they have pancreatitis, but it is certainly something for you to consider. And please consider the broad spectrum of differential diagnosis when someone comes in with abdominal pain. You still can't forget that it could be a biliary issue or a hot gallbladder or bowel ischemia or any of those things. So just make sure that you have a broad differential as to the etiology. And then they have generalized weakness. Now, obviously, you can have focal weakness if the stroke or a metabolic disturbance of some sort cause a focal issue. So in that case, of course, appropriate imaging would be warranted. On physical exam, I know that you can see everything that I thought that you couldn't see. So I guess I'll just go through it with you. We will often see a fruity odor, and a lot of people are like, I don't know what you mean. Okay, who has smelled the odor of someone who is in DKA? Dr. Luke. Dr. Witt is showing off with his little icons. Dr. Tim. I can't tell if Allison has. Yes, she has. It is not something Jocelyn has. It is not something you forget once you smell it. And sometimes it takes people a little bit to figure out that's what they're smelling, but people say it smells like a nail polish remover. I don't know if I agree with that, but it's definitely a very characteristic smell, and a little bit fruity, but definitely you can tell. I mean, you can sometimes tell in the ER, like walking by the room before you even go in to see that patient. You can say, well, does room 3 have DKA? It smells like DKA in there. Similar to how, like, Melena has a certain smell. DKA just has a certain smell. So pay attention to that when you take care of these folks, and it will help you a lot as you use your diagnostic skills moving forward. Often they have poor skin turgor or dry mucous membranes, clearly related to their dehydration. They can have those Kussmaul respirations, and they will have some tachypnea, often tachycardia. Hypotension can be present. They may have normal blood pressures as well. Sometimes with strokes or MI, they may even have elevated blood pressure, so don't let that throw you off as to the physiology that's still at work with DKA. Altered mental status is pretty common, especially just some fatigue, tiredness. Some people can have headaches. And then people can present with frank shock or coma. And then, like I said, sometimes they can present with focal deficits if stroke is the inciting factor. So what labs are we going to get? You guys are pretty familiar with these. I just want to run through them a little bit. CMP, of course, we're going to need to look at those electrolytes. We're going to need to look at the creatinine and see if they have an AKI potentially related to their dehydration. Also, the peek at those liver enzymes is really helpful because gallbladder or hepatitis can precipitate a DKA. So take a look at those LFTs. Also get a urinalysis because we know that infection can be precipitating, and do the culture if it's indicated. But as we know, a UA can tell us a whole lot more as well. That's where you're gonna see your ketones being spilled. You can also see your glucosuria that way. You can see if there's gross proteinuria and that sort of thing too. So UA can be very helpful. Urine pregnancy test in any woman of childbearing age is important to do. And then a urine drug screen is also very prudent. ABG, this test I believe is underutilized. You can use VBGs if you feel comfortable interpreting those. Sometimes folks just really don't have the comfort level or experience in interpreting VBGs, so just make sure that you feel comfortable and have some experience doing that, or are working with someone that does have experience interpreting a VBG. But I find ABGs very helpful in evaluating patients with DKA. And also, of course, on the CMP, the bicarb is very helpful, and you can calculate your anion gap that way. CBC is helpful to look for elevated white blood cell count. And then also you can look at your hemoglobin and your platelets, look at all 3 cell lines. Of course, anytime you do a CBC, you should be doing that to make sure that there's not like an ITP or something that you would be missing. Lipase is pretty helpful in most patients. Again, if it's mildly elevated, make sure you just trend that out and don't follow a rabbit trail, and just pin your diagnosis on pancreatitis if there's some other things that don't seem like they fit. Lactate can be helpful, particularly in the evaluation of sepsis or in the evaluation of a gut that may be hypoperfused. Blood cultures are helpful. A1C obviously is not going to help you acutely, but it's going to give you an idea of their overall long-term control. Serum osmolality is important to get because in some of, especially in the older patients, it can help differentiate your HHS patients, but also can be helpful in DKA. BOH, personally, and I'm open to conversation on this, personally, I don't find that very helpful. And I just think that it's not the most, hi, I'm giving a lecture. Thank you. Bye. That was fun. Personally, I don't find a BOH that helpful because it's only one of the fatty acids that's oxidized. It's okay. I know some people are just in love with it. I feel like the other stuff is fine, and it helps me just fine to figure out DKA. But I'm open to some discussion on that. So let me circle back to that in a second. Chest x-ray is important. I'm looking for infiltrates, CHF, those types of things as precipitating factors. And then I find EKG is very important. It really should be performed on everybody that has DKA because, as we know, patients with diabetes will often have silent MI. And so even if something else precipitated the DKA, you cannot rule out that they don't have an underlying MI. And so therefore, I should also add a troponin onto this list of things that you should get in a patient who has DKA. So anyway, now let's hear what you think about BOH. No one has any opinion on BOH.
I agree with you. I don't find them very useful as well. I mean, they're just a measure of ketosis, which I feel like it's sufficient enough from the urinalysis.
Okay. I'm not really sure who's speaking.
Sorry, it's me. It's Vasi.
Oh, hi, Vasi. Okay, awesome. Yeah. I agree.
I agree. This is WIT. I never used him when I trained. Of course, that was years ago, but I just never found that it adds anything to the picture.
Right. Yeah, and you will run across people, particularly emergency department physicians, that just absolutely love it. And I'm not trying to criticize that at all. I just personally have never found it that helpful. Particularly when you get everything else on my nice long list and include that troponin. Okay. I just put this on here. It's an up-to-date picture of basically your mild, moderate, and severe levels of DKA. And you can see to meet the diagnostic criteria for DKA, you only have to have a sugar of 250 or above. It doesn't have to be 600 or 1300 or some of those numbers that we see. And in fact, Dr. Schuh can differentiate some of those other numbers for you as they relate to DKA versus HHS. The arterial pH is really where I wanted to, and the bicarb, point you to. If the pH is less than 7, or the ketone or the bicarb is less than 10, that would be considered severe your DKA. And in many institutions, this would warrant ICU admission. This doesn't necessarily necessitate the care given by a critical care pulmonary doc. In fact, most of the time they'll say, hey, you go ahead and manage that. Let us know if you need help. In some institutions, any ICU admission does necessitate that referral, though. So please just make sure you know how it works in your institution. But if people have that much disturbance in their acid level, then we really should have them in an ICU type setting. And then you can kind of see the mild and moderate are in those other ranges. Once that bicarb gets up at that 19-20 range, I'm breathing a whole lot easier. I'm a lot less worried about that patient. And honestly, even in the 15-14 range, you know, it needs treated. Don't hear me wrong, but I'm not super panicked about that person. Once it gets below 10, though, that is very concerning, and we need to be very assertive and monitor those patients closely. Okay. So treatment, of course, like beginning with any treatment, you need to do your ABCs or BACs or whichever direction you follow from the American Heart Association. And then make sure IV access is established. It's better to have 2 IVs on these folks because they can pull them out, particularly if they have altered mental status. So it's really better to have 2 IVs if you can. Think similar to like if someone were bleeding. Get cardiac monitor and pulse ox on those folks. Monitor glucose at least every hour initially, because that's going to help you adjust your drip, which nurses do now. I remember when I was a resident, Dr. Bird always talked about how he would have to go up to pediatric floor or to the regular floor and make adjustments in theophylline drips, and we would laugh, ha ha ha, that's amazing, that's funny. Who's on a theophylline drip? But when I was a resident, we used to have to make all of the adjustments. We got called every single hour for the glucoses, so we had to make adjustments in the insulin drip. So now you guys are all saying, ha ha ha, who adjusts an insulin drip? Because the nurses do that for you. But it's important for you to at least know that is happening and kind of the basics behind it, and we'll talk about that in a minute. You definitely want to monitor electrolytes every 2 to 4 hours, early on in the admission, and then once things start to stabilize, you can spread that out to 4 hours. And then of course you want to identify and treat any precipitating cause, because if you delay treatment for that, obviously it has ramifications for that process that's going on, whether it's a pneumonia or a stroke or heart attack or what. But it also has implications for the treatment of your DKA, because if you're not treating that underlying precipitating factor, then that DKA will still continue to be an issue. All right, so the mainstay of treatment, we talked about fluids and insulin, fluids and insulin, fluids and insulin. So we're gonna start with fluids. You wanna do a 15 to 20 ml per kilogram per hour. Initially, usually that will give you 1 to 2 liters. And remember, this is for lean body weight. This is not for their actual weight. So this is really based on ideal body weight. So be careful in overdoing it on the patients who have obesity. And then after that initial treatment, you want to go to half normal saline at roughly 250 to 500 mils an hour. And I get that because you want to keep an idea of the maintenance fluid, and then you have to add into that the calculated deficit. So you have to figure out how dehydrated do I think this person is, how volume depleted do I think they are, and then whatever volume you think that is, you give half of that deficit in the first 8 hours. So you do maintenance plus half of their deficit plus any ongoing losses that they're having, whether they're insensible losses, whether it's vomiting, whether it's raging diarrhea, whatever. You have to take into account all of those things when you're calculating your rate. It's not just the maintenance IV fluid situation. And then once that glucose is between 200 and 250, usually right around that 200 mark, you add your D5 to your maintenance fluids, and that is to maintain your glucose levels right around that range, right? We don't want them to get hypoglycemic through this process. And this is an area where you may get some pushback from nursing personnel, particularly if they're a newer nurse or on a different floor or something like that. They're not accustomed to seeing D5 added to IV fluids. Why are you giving D5, doctor, when you're also giving an insulin drip? So be very prepared to explain that to your nursing staff. Anybody ever have themselves questioned when they're adding D5 to the fluids?
Yeah. I haven't had questions about that from nursing, but I have had questions about stopping the insulin drip and initiating sub-Q insulin. Like if they say that their blood glucose is like 100 to 120 and they want to stop the drip and they don't understand why we need to initiate sub-Q insulin.
Right. So okay, we'll get to that. That's a great point, Stephanie. Thank you so much for bringing that up. We'll get to that when we talk about insulin, okay? All right. So then potassium, I just want you to be aware that those initial levels may not be indicative of body stores. So keep a very close eye on the potassium. People with diabetes generally have low stores of potassium and magnesium for that matter, so they usually need some at baseline, plus that now they have a DKA process going on, which is going to waste that electrolyte, and so they're going to need more than you think they're going to need. However, if they present with an elevated potassium in the 5.3 or 5.4 or whatever range, you don't have to supplement it right away, but don't rest assured that that's where it's going to stay. It's probably going to drop, and it's probably going to drop significantly, particularly once you initiate insulin, because that causes the potassium to go intracellular, and so the serum level is going to go down. So it's really important for you to keep such a close eye on that potassium and not be reassured by a normal level to start with. Now, if the potassium is high, above like 6.3, 6.4, you do not give any potassium to these patients. And I have a little treatment thing I'll show you in a second. Make sure you do that EKG early on all patients, and that way if there's any rhythm disturbances that develop, you'll be able to tell if they're new or old. And it's best to establish urine outpatient in patients, but sometimes if it's low, don't worry if they're peeing or not. You really need to give them potassium, particularly if they have ileus or hyporeflexia or any kind of abnormal EKG or rhythm changes. Then you have to go ahead and proceed with plate replacement. Usually they need about 80 to 160 milliequivalents in the first 12 hours. So don't be alarmed if you're having to give more than what you normally would. And if you feel uncomfortable or you're not sure, then please call us or call your attending or whoever and go over it. We don't want you to do something you feel uncomfortable for. I'm just letting you know that it could be more than what you would normally feel like. Should I be giving 160 milliequivalents? But that's not terribly uncommon. Here's that little treatment thing I was telling you about. This is from Up to Date. So you establish renal function with a good urine output, and then if your K is low, you want to hold off on that insulin briefly while you give your potassium so that you don't drive more potassium intracellularly and drop that serum potassium even lower. And then usually you're going to see it though in that 3.3 to 5.3 range. Go ahead and start giving potassium. And then if it's above 5.3, you don't give it, but make sure you keep a close eye on it, like I was telling you. All right, phosphate is generally not recommended for treatment in DKA. It can cause hypocalcemia, and the studies show there's really no difference in outcomes. So really don't need to use phosphate. Bicarb, there's really no evidence to suggest it works in most cases, so it's only used in very select cases, and generally those times are if the pH is under 7 and there's some cardiac contractility issues. Sometimes bicarb will help for those patients, or if the potassium is significantly elevated, it can potentially help with those people. And sometimes you'll see DKA in like your end-stage renal disease folks or those types of scenarios, and that's when you would see potassium in that range, and those people may benefit from bicarb. Okay. All right, here we go. Here's the insulin. So IV is the treatment of choice. We have some folks like the guy I was telling you about that we took care of a few weeks ago that was pulling out his IV and refusing his insulin drip, and we ended up having to treat his DKA with sub-Q. But the great majority of time, you're going to take care of DKA with IV insulin, and what goes in an IV insulin drip is regular insulin. And the rate should decrease that serum glucose by about 50 to 75 milligrams per deciliter per hour. So we have some basic bolus information here that I wrote down for you, but you want to get that glucose under 250, and then you kind of pull back on the rate. And again, the nurses have like a protocol algorithm that they follow. If the glucose is this, then increase it by this many units. If the glucose is this, then decrease it by this many units. But you guys really should take a look at that order set and how they adjust it so that you're familiar with how insulin drips are run. The main goal is to stop the ketogenesis and reverse the acidosis, and that's what Stephanie was talking about, because a lot of times the nursing staff is very confused about why are you continuing an insulin drip when the glucose is in the 100s, but yet the bicarb is still 13. So you have to explain that the gap is not closed, the patient's still acidotic, and that we have to continue the insulin drip until that acidosis is reversed. And remember that glucose control is almost always achieved before the acidosis control is achieved. So then once that gap is closing and the acidosis is clearing, you can change to sub-Q insulin. But take into account several factors. One is see if that patient can eat. If the patient is still actively vomiting or is undergoing a procedure or something like that, then switching to sub-Q insulin may not behoove that patient very well, because you don't even really know how to adjust the sub-Q insulin if they're not eating. So if they're feeling a whole lot better and ready to start some clears and things like that, then you can change it to sub-Q insulin. The other thing to keep in mind is, what if the gap closes at 2 in the morning? What do?
If you're me, you put your transition to sub-Q insulin in plan pending before you sign out, and then all your night team has to do is just sign it and activate it.
So if you're on the night team and you were lucky enough to follow Jocelyn, then you have everything in there, right? But then what? What if it's 2 in the morning? What do you give them?
Yeah, I think one of the problems that we run into is a lot of our patients on Basaglar or Lantus, they get that once per day, and we can split it and give them twice a day in the hospital, and that make adjustments a little bit on a little more frequent basis. But that can be an issue. One thing I've done in the past is to give a single dose of NPH to last approximately 8 to 10 hours or 8 to 12 hours. Until they would normally get a dose of something that's more of a 24-hour insulin.
Right. Yeah. And that's 100% fantastic idea. Now, if the person's already on like a Lantus twice a day regimen, you may be able to go ahead and start that regimen at 8 a.m. and then continue it at 8 p.m. or whatever time they're getting it. But if they aren't due for their nighttime insulin and their gap closes at 2 a.m., then you can give that NPH in the morning to get them through to the nighttime dose. And that is a trick that is going to help you so much in treating these patients. However, one of the points I want to get across to you is that if the gap closes at 2 a.m., you say, wonderful, that's fantastic. Let's continue the drip until 8 a.m. What is the urgency to stop that drip at 2 in the morning? There is no urgency to stop the drip at 2 in the morning just because the gap is closed, because it doesn't align well with the sub-Q insulin. You want to be able to give the sub-Q insulin prior to the discontinuation of the drip. If you discontinue the drip at 2 a.m. and you have nothing there for that patient that works with the time frame of their longer acting insulin, then they're going to go right back into DKA. They just are. So there there is nothing wrong with going ahead and continuing that drip for another 5 or 6 hours until they are a better candidate for something like NPH or their regular insulin regimen. Does that make sense? Okay, you may get pushback on that, but it helps a lot to be able to do it at the right time of day. Okay.
Hey, Dr. Bunch.
Yes.
Can you talk through the order set we use for the insulin drip? At one point I chose a DKA order set, and the nursing staff was just mystified. Do they have like a floor protocol, and as long as we choose IV insulin drip, everything will work out, or?
There is a insulin drip order set that's not for DKA, and then there's an insulin drip order set that is for DKA and HHS actually. And so to answer your question, yes, it'll probably work out, but the labs and all the other orders that go with the DKA one are very specific for that and HHS diagnoses, as opposed to some people that need to be on an insulin drip in preparation for a surgery or something along those lines. Or maybe they just have terrible control and you've tried everything and you just need to use the drip to get them under control. So there are a couple different order sets. Yes. I don't know if that helps you. But
No, that is, I think my issue is I went for a DKA order set instead of insulin drip DKA, like you just said. I think that's where I ran into trouble.
I believe, and someone correct me if I'm not telling you the right thing here, I believe it's called insulin infusion. Okay, I'm going to assume that everything I say is amazing and correct unless I hear from you. All right, here's some complications here. Cerebral edema, this is the biggest one. This is the most scary one. It's most common in kids who have new onset diabetes. Symptoms develop in the first 12 to 24 hours, and they have headache and lethargy, and they can get seizures and other mental status stuff. You do want to avoid this by slowly correcting the sodium and water deficits. So make sure you're paying attention to their free water deficit and their volume depletion and all of that. You also want to avoid rapid correction of the hyperglycemia. Mortality rate is high, so this is the biggest thing to avoid, and you want to monitor all your DKA patients closely for any neurologic changes. Complications, we have hypoglycemia. If we over zealously treat with insulin, or we don't do fluid management correctly, we don't add that D5 in. We can have hypokalemia.
I think I can do formula.
And that's from administration of the insulin, because we know that causes it to go intracellular.
Obviously try and do it in the skin fold and pull it together.
And then hyperglycemia, of course, if we don't, if we stop that insulin therapy too soon. Hypoxia. You can have cardiogenic pulmonary edema, particularly in patients with reduced ejection fraction. So pay attention to how quickly you replace their fluid and keep that in mind. And then you can also have non-cardiogenic pulmonary edema, followed oncotic pressure.
I love Clarence.
I hear Dr. Wilson laughing.
I'm in clinic. I might try to stop back there though.
Okay.
And say hi to him if I can.
Okay, I just muted her. Anyway, mortality rate is thankfully pretty low in DKA. So that's good. All right. So I had another section of this to go over managing some tips for managing insulin in the hospital, but it's 12:46, so I want to pay attention to the time, and I can do that another time, or we can do it today. It just depends on how you guys are feeling and whether or not you want to talk more about DKA and have some more questions.
I have a quick question. All of our pediatric patients are basically getting transferred to Riley if they have DKA.
Yes.
Is that my understanding? Okay.
Yes. Thank you for bringing that up. There is, and Dr. Wilson told me about this yesterday, there is a new DKA protocol, insulin protocol, as well as an order set for other issues. In Cerner for kids, there is a specific pediatric one. However, yes, we would be transferring any DKA to Riley. We do not do insulin drips for children on our pause floor. However, if you're working in the emergency department, you may need to initiate that order set. And so big thanks to Dr. Wilson for letting me know about that, so that you guys are aware that there is an insulin DKA order set that you can initiate in the emergency department. Thanks, David. Any other questions, or here's something in the chat. Warren's all in. Okay, good. All right. Do you guys want to talk about insulin? You want to just do another day? You guys, no opinions?
I'm happy to hear more.
Sure.
All right. All right. I just want to go over a few things. Why do we even worry about elevated sugars? This is another thing that I was hoping to get some participation on, but since I created it so that you can cheat, I'm just going to go over this with you. Obviously, some of the fluid and electrolyte imbalances that we've talked about already can cause that osmotic diuresis. So it can be a big disaster for us to have elevated sugars in patients. And I'm not talking about DKA anymore. I'm just talking about people that come in, you know, they have those elevated 300, 400 sugars. And then sometimes we really struggle to get those people under control. And so one of the reasons that we care about getting it under control is because of these issues. And it can also decrease the function of the white blood cells. Because it's pro-inflammatory, it actually does also reduce the efficacy of the macrophages. And so sometimes people come in with infection. One of the reasons they don't get better when their sugars is elevated is because we're impairing the ability of the white blood cells to do their thing. Delayed gastric emptying, we know about chronic gastroparesis related to poor glycemic control longitudinally, but even acute elevations of glucose can decrease delayed gastric emptying. And in our patient population that we care for on the inpatient side, this can be a big disaster, right? Because they can have aspiration and other issues related to those delayed gastric emptying concerns. And so just keep that in mind as we look at controlling sugars. We also talked about increased circulating catecholamines, and so some of those stress hormones that are released related to that can impair healing, as well as increase the risk of those nosocomial infection rates. It's interesting, it's 5.7 times higher with a glucose over 200. That's why our goal is to try to keep those glucoses under 200 and avoiding hypoglycemia. It increases our length of stay, so you're going to get a bunch of calls from utilization review, and it also increases mortality. So that's why we worry about elevated sugars. Our goals for hospitalization are to keep those sugars between 1 and 200, and again, avoiding hypoglycemia, because we know that can be very detrimental as well. We want to educate the patient. While the patient is a captive audience, there is no better time than to get somebody in there and talk to them. Now, yesterday, I think Lauren had to practically barter and exchange with the diabetes education team to go in and see a patient who had a COVID pending test. It's like when they're COVID pending, we won't touch it. We won't go in the room. If the COVID's positive, we'll still go in the room, or if the COVID's negative, we'll go in the room. But if it's COVID pending, for some reason, we just won't go in the room. So if you have issues with this, then please just call them personally and tell them we would like for you to go in and educate the patient. But my point is, just make sure while you have a captive audience that you identify any barriers that they may be having to managing their sugars at home. The other thing that's really important and that sometimes we don't do do with our patients is we don't feed them. Obviously, if they have contraindications to eating, then please don't do that. But if they don't have contraindications to eating, then don't give them some measly like 1,000 or 1,200 calorie diet. Make sure that we give them plenty of calories, because most of the time that they're in the hospital because they have some sort of stress event, and they're going to need the calories to recover from their pneumonia or whatever it is that they're battling. So please remember to feed the patient. And then make sure there's no interfering medications. There's a huge list of medications that can elevate sugar, including some of the ones that we talked about. Steroids is the number one culprit, but you have your thiazides and your beta agonists. Also, calcium channel blockers can elevate your glucose, in addition to some of the antipsychotic medications, and caffeine and nicotine can also elevate sugar. So keep in mind if there's some extenuating circumstances that are causing those blood sugars to be elevated in the hospital. When we're looking at what patients come in on and what they're being treated for on the outside, what medicines do we continue? What medicines do we get rid of? Sulfonylureas, pretty much across the board, I get rid of that immediately when someone comes in the hospital, because they have very unpredictable eating patterns. They may be waiting to go down for a radiology test. They may miss a meal, those types of things, and they're just going to bottom their sugar out. So I really stay away from sulfonylureas in the hospital for sure. Metformin in your mildly sick patient that comes in for a simple pneumonia or something can generally be continued. However, if they've had a contrasted procedure, most of you are aware that you have to hold that metformin for at least 48 hours. And if they're super sick, then it really does increase the risk for lactic acidosis and things along those lines. Or if they have an AKI, then I hold that metformin because it can actually make things worse. These other medications can sometimes be continued depending on the severity of illness as well. In looking at our insulin types, I just listed sort of the 4 most common types, and Humalog is similar to like Lispro or one of those. So you can kind of interchange those. Regular insulin, has an onset within an hour and it peaks at 2 to 4 and lasts 6 to 10. But those shorter acting insulins that we use can peak in 1 hour and have an onset in 5 to 15 minutes. So just keep that in mind. The other thing is some of your like glargine and Basaglar and some of those are supposed to not have a peak. They're supposed to be flat, but in some patients we know that they don't really aren't eliminated that way. So keep that in mind. They last roughly 24 hours, but some people, as we know, have to be dosed twice a day for that. The other thing I really want you to remember is that your insulin is always cleared renally. So any changes in creatinine are going to change the clearance of your insulin. So if your creatinine bumps up, then you're going to hold on to more insulin and increase the risk for hypoglycemia. So you may see your patients with AKIs and things along those lines needing less insulin at times than what you think, and you may be scratching your head and like, well, why is that? And that's because the clearance has decreased some, and so you may even experience hypoglycemic episodes. So keep an eye out for that. Sliding scale is definitely not sufficient for monotherapy, and it causes a terrible roller coaster effect. And so we sometimes will say, oh, we'll put them in, stick them on a sliding scale and kind of see what happens. If their sugars are in the 300s and 400s when they are admitted, that it's just not going to help you that much to do that. Now, if they're mildly elevated and you think, well, let's just put them on a sliding scale and see if they actually need any insulin, that's fine. You can do that. But be very aware that that is a temporary thing so that you can figure out if they're going to need basal insulin. Some people who have mild diabetes or have diet-controlled diabetes or maybe on a little metformin on an outpatient, when they're sick in the hospital, they may need insulin, and you guys have seen that particularly in the ICU setting. So, and obviously type 1 diabetes can go into DKA if you use a sliding scale as a monotherapy because they need basal insulin. They need the pancreas you need the insulin that will mimic what the pancreas would normally do. And then you also risk undertreatment in individuals who are insulin resistant. It's nice that we have now come up with scales that like are the AABC, and they take into account the degree of insulin resistance. But typical scales, even ones that are written for insulin resistance, can be short of what that patient needs. And that's one of the things I just want to emphasize Anyone heard of the 1500 rule before? I'm just curious if anyone's familiar with it. I don't know. I can't tell if you are or not. Dr. Witt is. Okay. Hearing nothing else, I just want to go over it really quickly with you. Basically, you divide the total daily insulin that someone gets into 1500. And what number you get will determine the amount of glucose drop per unit of regular insulin used. Then you can use that calculation to develop an appropriate sliding scale. And so you can see where this is going, right? If they are on a total daily unit of 30 insulin, total amount of insulin a day of 30, then they're going to have what? 50 drop? 50, am I doing the math right? That's always risky when you start to do math. You have a 50-point drop for every unit of regular insulin used. Whereas if that person is on 150 units of insulin a day, they're only going to have a 10-point drop for every unit of insulin used. And so if you give those two people the same sliding scale, you're going to get vastly different results and you're not going to achieve it. I've written many customized scale for patients using this rule because some people end up needing a whole lot for their sliding scale to get them to actually get into goal. And then remember, you're always reevaluating your sliding scale so that you can kind of put that back into your regular regimen. 1800 rule is for the short-acting insulin, and it's the same as your a 1500 rule. You just used 1800 instead of 1500. So here's a little slide that helps you understand what I'm saying. If your total daily insulin is 20 units, then you get a 90-point drop if you're using Humalog and a 75-point drop if you're using regular. Whereas if you take 60 units a day, you're getting 30-point drop and a 25-point drop. And that will help you calculate your sliding scale. And if anyone wants to practice that or talk about it more, you just let me know. But we are at 12:59 now. Any last questions or thoughts?
Allison had a question in the chat.
Okay, I'm trying to pull the chat up. I don't know why it's acting wonky right this minute.
Yeah, Allison, that's a good question. Do you want me to read that off, Jen?
I see it now. Talking about making sure patients eat, I was wondering your opinion on carb-controlled diets in the hospital. I've talked with some attendings who don't like using the carb-controlled diets in the hospital because you don't get an idea of how they actually eat at home. So it can look like they're well controlled in the hospital, but insulin isn't sufficient when they get home. Yes, this is perfect. This is a classic scenario of an issue. Now, in some patients who are coming in, and one of the primary reasons that they're there is to help with their diabetes education and things, sometimes I find it helpful to give them a carb control diet so that they know, oh, this is what my plate should look like. But I think if we really want to, and exactly what Dr. Witt said, if they're not motivated and we know they're not going to change, then give them a general diet or a low cholesterol diet or whatever it is that you want to give them without the carb control component. Then you can kind of see where their sugars are and get them on the better regimen that they'll actually survive on at home, you know, and bring that A1C down. But that's a great question. And also for sick patients, sometimes, you know, doing the carb control, it doesn't help that much. They just need the calories. So just give them a general diet. And then Jocelyn says, Doctors Bunch and Witt, when you use NPH instead of the split Lantus concept during transitioning, how successful are you controlling blood glucose? In my experience, it's fine. It gets you through to the evening. You have to do an accurate calculation, of course, based on what they are supposed to be on at home and based on what they've used on their drip. You have to do an accurate calculation. And then, and like Dr. Witt is saying, you do need to start that NPH an hour or two before you stop the the insulin drip. Because remember that when that slide that I was showing you about the washout, it's really fast, especially when it's given IV. So you have to have something on board that's going to peak at the right time so that you can DC that insulin drip. But the NPH it is wonderful to get them through to when you need to get to the Lantus or Basaglar or whatever they're on. Any other thoughts?
Oh, we'll just make one more point. I was starting to type it out. I don't think I can type fast enough. I was just going to say that, you know, as you're transitioning, you can calculate the hourly insulin rate from the drip. And that's honestly the nicest feature of the drip in my mind. It gets them under good control. But the best thing is you can figure out what is their hourly insulin requirement, at least for that day. And that's probably in a state where they're not eating. But you can use that to say, well, I know that the drip has them controlled on, I don't know, let's say 1.5 units per hour. I can take that and divide, or I can multiply that out, the number of hours that they've been at that rate and that they've been controlled, and then I can calculate their daily insulin needs. And then you can titrate up as they start eating more. So that's a good way to do it. And that's what I would use to base my initial dose of NPH from.
Yeah, and that's really great. And we can talk more about, in fact, if you want to have another session just on like using some of that data and then how do you convert that and create that into an insulin regimen, we can absolutely do that. Vasi's asking a really great question, and I 100% agree with her. How familiar are nurses with carb counting patients' meals? I notice most mealtime insulin is a set number rather than a carb ratio. Because when you learn how to do carb ratio insulin administration in your diabetes education, patients that are really good at it are like, they know if I have that cake, here's how much insulin I'm going to need versus if I have, you know, a salad, this is how much insulin I'm going to need because of my carb ratio. And unfortunately, those patients aren't the ones, well, fortunately for them, they're not the ones in the hospital as much. And so for me, I feel like one of the reasons that we do more of the set number than a carb ratio is because the patients that are in the hospital just really can't always administer that accurately. But I honestly am not really sure with how familiar the nurses are with dosing insulin that way. Our diabetic educators obviously are very familiar with it, but I'm happy to hear anything from Dr. Witt, Dr. Wilson, Dr. Shu. I don't know.
Yeah, I think the thing that makes that really hard practically is that that number differs between patients. You know, every patient has a different sensitivity to insulin and would have a different carb ratio. And so it's very impractical to be able to figure that out in my mind.
And like I said, most of the patients that like grasp that and understand that, they're usually a little bit healthier and better controlled. And they're not the ones that we're seeing quite as often in the hospital, which is good. Any value in getting ISF and new onset DKA, or do you save that for endo follow-up? I save it for endo. Yeah. Good question. Good discussion. Well, again, you know, this is just kind of scratching the surface of managing insulin in the hospital, but we wanted you to feel a little bit more confident and have some tools for DKA and then just generally taking care of folks in the hospital with insulin and who have diabetes. So if you have specific questions, let me know. Happy to talk with you. I know all the other directors are too. So, and then again, if you have any ideas or want to talk more about it in this type of format, just let me know and we'll develop a lecture for that. Thanks everybody. You guys have a great day.